Welcome, Holger, for our workshop. So I let you to explain us for your specialty, and we will go on Narval oral appliance after that. I'm very happy to welcome you.
Merci, Darius. My name is Holger Woehrle. I'm a respiratory physician and sleep physician in Germany. Germany has a dual medical system. We work in a hospital-based system and in an office-based system. I'm running together with my partner an office-based system. We're the largest provider in southern Germany of respiratory and sleep health. We're running every night 9 PSGs and roughly 15 polygraphies and seeing roughly per year between 5,000 and 6,000 patients with sleep apnea and roughly 2,000 with sleep disorders in the lab. And I'm absolutely happy to be here because I think we need to discuss more other therapies than PAP therapy. There's two things where we do things wrong in sleep medicine, from my point of view, in respiratory sleep medicine. There's two hypotheses that I want to share with you that I think we're going to learn during our presentation that Darius and I prepared together, that we're doing things suboptimal. Number one is we think that our therapy goal in obstructive sleep apnea is to put a mask on a patient. Yeah? And that's not our therapy goal. Our therapy goal is to treat a patient. It's got nothing to do with a mask. But it kind of like, because we're treating so many patients with masks, got to the point that everybody has the feeling if you refer somebody to a sleep physician, his goal is to put a mask on the patient. And we need to change that. That's number one. And hypothesis number two that we're going to discuss with you with the treatment of MRDs is that we're way too much focused on AHI. Yeah? If there's a Facebook group called AHI Lovers, I think we would all be part of that. And I think that's wrong. Yeah? And I'm going to show you a couple of slides and equations in here why having the sole focus on AHI is not good, proper respiratory sleep medicine. So there's a couple of things where we want to show you, our practice, where we want to discuss with you how we can work with MRDs, get them more utilized. And there's a couple of also thematic slides where we want to discuss with you how we should change our clinical strategy. Okay?
Very good.
Shall we get going? You start.
So, the treatment will be in a multidisciplinary patient follow, and the sleep doctor will make the diagnosis and then ask to the dental specialist. In France we could be this one if you are a surgeon, head and neck surgeon, but it's almost for dentists, and to use this Narval oral appliance, and after manufacturing with the Narval Resmed, we have to follow the patient with a protocol that we will maybe talk later.
I think it's very important what Darius said is it's a multidisciplinary team. When we come later to challenges, for example, that we have in Germany, that's the challenge that we have, because it needs efforts from the dental. Does that one here work?
Yeah, because on the screen you will have this pointer.
No problem. But if we think about the dental specialist, he's got a different practice of medicine than what I call the normal physician. Yeah. And that creates opportunities but also challenges. And I think that's something we need to discuss during the workshop, how we make that work. And for example, Germany is an example where you rather have failed over years to get that working than we succeeded. Yeah?
Yeah. So, an MRD, and mandibular repositioning device, is a custom-made, prescription-based, it's very important, adjustable oral appliance and available only from a dentist or head and neck surgeon in France. And the MRD is intended to treat snoring, very important for ENTs, or obstructive apnea in adults by maintaining the lower jaw forward a little bit, maybe about 5-6 millimeters, and the positioning during the sleep. This mechanical protrusion is designed to widen the space in the aura, in the pharynx. So you will reduce the vibration and the physical obstruction that the OSA will be the reason. So you have some picture to explain that. I think it's very clear for you with your high level, so you can go on maybe.
So what important is, normally we have the challenge in medicine that we don't have evidence, but we have clinical practice. Yeah, that's often the case. Yeah, the Germans are the worst in that. You know, normally we get a new device and we'll overtreat patients before we have the evidence. That's typical German practice. Yeah, in MRDs, it's completely the other way around. We have much better evidence than we think, but we don't utilize it. Yeah, and we've put in a slide set. We'll go over it a little bit quicker, but we put in a slide set the complete evidence that is existing, and you will also learn that the evidence is not really fresh. You know, it's not new. Yeah, but in this case, you know, we have good evidence. It's in guidelines. Yeah, it's in guidelines, very clear. But in most of the European countries, I think, except France and Sweden, where there is a good practice with MRDs. Other European countries, although we have the guidelines, have failed to deliver on that. Yeah, and the first oral appliance review was in 2011, and you know that the Cochrane reviews are kind of like the motherhood statement in Europe, always around evidence. And they did that. I've got all the slides in there for you, but to summarize it in respect of time is. They already showed at that time that we're getting an effect on reducing symptoms that is similar to CPAP. And when you compare CPAP and MRDs, there is no difference. In 2011, where the technology wasn't as much developed in terms of MRDs compared to CPAP, you know, we already had 30 years of CPAP and roughly 10 years of MRD. So there was a technological advantage for MRDs. But very briefly, you know, we get an Epworth sleepiness reduction of around 2, yeah? If we compare that with CPAP, you know, there is meta-analysis for CPAP, also for mild to moderate obstructive sleep apnea. It's the same result. It's not better. If you ask most of my colleagues, they would say, no, CPAP is better. No, not at all. You know, the results of the trial say it's the same, yeah? And if you compare already in 2011 CPAP and oral appliance, no difference in terms of symptoms, okay? But then comes into play that most of our colleagues said, well, but what about cardiovascular? I think we're overestimating the effects of CPAP on cardiovascular because it's got so many other risk factors. So Malcolm Kohler and team did a meta-analysis a couple of years ago on blood pressure, yeah? And there's also good blood pressure data on MRDs. And what you can see if you look at blood pressure, which is an important outcome for treatment of obstructive sleep apnea, it doesn't matter if you look at systolic or a diastolic blood pressure. You see it's right on the middle. There is no difference between MRD and CPAP, you know. So I think we should overcome that notion that we think one is more effective than the other. I think we should respect the data, all the work that other researchers have done for this treatment, and we should clearly state, like the guidelines do for Europe, yeah, that the evidence supports that we have 2 excellent ways of treatment and one is not inferior to the other. And what we should think about in the future is, right now what I don't like about our German approach is this, you have to fail one treatment to get another. It's like I said, you know, you put a mask on everybody and then you first have to fail a treatment to get another. And I think that's bad medicine, yeah? If you need, because think about the patient perspective. If you need to fail, yeah, you have a negative experience in that disease area before you get to a positive one. That will change your second experience, okay? And that's why we think, you know, we all talk about precision medicine. It's coming from cancer, but in the future, we should rather think about phenotyping patients that we know who needs a PEP, who needs an MRD, who needs a hypoglossal nerve stimulator. And instead of making them fail all the time, you know, getting the right treatment for the right patient at the right time and involve the patient in that decision making. I think that will be very important. So patient selection, a lot of colleagues ask me now, who's a good patient? Yeah, we know that if you have a BMI over 40, if you're obelix, you know, you're lost, okay? As soon as you're obelix, you know, you have central warehousing, you're gone, okay? But other than that, you know, very simple how we train some of our colleagues, what helps is if you're like a nice comic figure, you know, if you're, for example, Charlie Brown, Snoopy, they all snore. Why do they snore? Because they have you have a high pretest probability that you have obstructive sleep apnea, yeah, especially females, lean females who snore, micrognathia, big problem, yeah. And those are candidates, you know, excellent candidates for MRDs. As an example, just that we think about patient selection. If you're like the villains in movies, you know, like the dolphins here, villains, when it starts raining, it rains in their mouth, okay? So when it's already raining in your mouth, you're not a good candidate. What do we want to do with an MRD, you know? Yeah. But so we have to think much more. That's just a very simple example about patient selection.
Very nice.
If we look more into our everyday clinical practice, we can already right now identify patients who would be, at the start, optimal candidates for MRDs rather than make them fail with CPAP. There's one more slide that I want to do, and I'll hand over back to Darius. Of course, we all do lots of CPAP trials with the patients, but if you do one, then also use the CPAP treatment to identify your patient who is eligible for another treatment. And CPAP pressure gives you a very good impression about the mechanics of the upper airway. Yeah? If you need a CPAP pressure of 18, yeah, which is, for example, Obelix needs 18, yeah, Asterix needs probably 5 to 6, okay? If you need a CPAP pressure of 18, MRDs probably won't work. Yeah, if you have what most patients have, CPAP pressures in the range of 5 to 9, there is evidence from this trial that shows MRDs work very well. Because CPAP pressure is also something that tells you something about the mechanics of the upper airway. So lower CPAP pressures means excellent outcomes for MRD. So if you're not sure your patient will be a good candidate, you can do a CPAP trial, a successful one, and look at the pressure which the device gives to you, and then you can take a very good decision. So to hand over to Darius Beck is, think about treatment of sleep apnea. It's my hypothesis number one that I wanted to share with you. More that you have a variety of options. You have surgical technologies, you have MRDs, you have hypoglossal nerve stimulating. We're forgetting always 2/3 of our patients are too small for their weight, okay? And either we make them grow or we get them to lose weight and exercise. That's why we're not seeing cardiovascular benefits. Yeah, if we don't improve them, they won't get better. So we should get away from this CPAP for everybody and it fixes everything to an individualized approach, looking at different treatment possibilities. And what we have to see is a great treatment is upfront already MRDs for obstructive sleep apnea. Perhaps I'll stop with that and then hand over. Just in terms of reimbursement, I can tell you the German story, what the problem is. Yeah? The reimbursement in Germany is right now under revision. I can tell you I'm one of the two heads of the German Society of Pulmonology for the working group on sleep medicine. And the German Federal Council for Health has asked now the societies to give their opinion on MRDs. And the evidence is so good that we expect in the next 2 years to get reimbursement for MRDs. The reason why that didn't happen is health politics, okay? Who is doing the MRD treatment? In Germany, it's the dentist, okay? The dentist works mainly in Germany for private pay. I'm a public health physician, you know, my income is 85% from public health insurance. If you're a dentist, it's the other way around. Most things for teeth you have to pay out of pocket. When you pay out of pocket, you can negotiate a price that is not only much higher than in the public health system. As soon as something comes to the public health system, the price goes zzzt, yeah? So the dentist is not really interested from a financial point of view to get this into the public health system. Yeah, of course. I mean, understandable, yeah? That's not a medical point, that's an economical thing. And that's why we didn't have it, because the dentist didn't push for it. Because they rather make 20 patients with with a high payment than 100 with low payment. Very simple, okay? But that's why it needed the sleep physicians approach, you know, and sleep physicians in Germany haven't been very good with health politics, but that's why I needed our approach now, and I think this time we're going to be successful. So in the next 2 years, I think we'll receive reimbursement. But I think we see that with the different practices, and I'm very interested to hear about the French situation, though, is it doesn't, in modern medical times, it doesn't only need evidence, but also health politics to succeed with a treatment. Yeah?
And so in our country, in France, the situation is quite different, you know. And we have maybe more than the other countries for using the MRDs per year. And the reimbursement is the second one in Europe. Have you seen that? It's Sweden before France. But in France in 2009, it was a very important for us. And we completed in 2016 with the complete reimbursement. It's incredible. So that's why maybe we have so much MRDs, so many MRDs per year. It's okay. But the Narval was a French MRD created by our colleague. And so I think that maybe prices will grow.
Sure.
And I don't know what will be the reaction of our national security, but I think it will be they will follow because they want patients to be more with an oral appliance than with a CPAP. And so I wanted to precise another issue in indication. Have you seen the first slide with the classical indication? Doctors, please come and think with like a patient. A specialist will tell you you have a severe apnea, you have to put a mask on your face. Maybe it's a chronic problem, disease, maybe all your life. So when you have a CPAP, you could buy an oral appliance and use it too, you know. Sometimes to have less pressure with your CPAP, and sometimes when you are fed up, when you have difficulties with your CPAP. So please imagine and let them maybe a psychological escape of CPAP therapy. You know, it's very important. And we have much problem with that. Many patients with a CPAP for the principal treatment and an oral device for travels, for maybe a weekend or difficulties and so on. It was an important indication, but it's not classical, but it's practical.
Absolutely. But that's what I like about your approach. It's a patient-focused approach, not a disease-focused approach. The patient is in the middle of it. And what I think is what all the countries with Germany have to admit, we've got all of these latest epidemiological data, how common sleep apnea is. You know, it's a mass disease like diabetes, you know, like hypertension. And then, you know, we only have one treatment available, and all of the other patients, you know, have no other option.
Yeah,
it's
very difficult.
That is not good.
Psychological difficult.
Absolutely, yeah.
Very good slide.
So, yeah, so that speaks, it's the most sophisticated slide that we're showing this morning, so you have to stretch your mind, okay? So what we're always thinking of in terms of that CPAP reduces the AHI the most, okay? And that's why we think it's the best, because we are AHI lovers, okay? But what we're not thinking of is, on the one hand, that most patients wear CPAP for 5 hours a night, and most people sleep 7. So there's a gap, yeah? That's number one. Number two is that we don't take into account, because we're sleep physicians, our goal has to be to improve sleep. That people could get to an AHI of 2, but while they're getting to it, they sleep worse, okay? And I'll make for you a very simple calculation. It's trying to break the sophistication down. I created what I call a residual sleep apnea disease burden, okay? So what's left, okay? Instead of looking at I have an AHI of 2, we'll look at what's left, okay? So take a patient from our clinic. He's got an AHI of 30, he sleeps 8 hours, okay? He's working in the public sector, not private, so he can sleep longer, and that's why he's sleeping 8 hours a night, okay? So he's got 240 respiratory events a day. You got that? Okay?
Yeah.
We're trying to get your cognitive function up and running, okay? So, therapy. We said AHI of 2, okay? Yeah, he was in our sleep lab, so he's very compliant, yeah? But very compliant means 6 hours a night. So he's got 2 hours left where he gets his sleep apnea back, okay? Yeah? It's not very biological, because normally your AHI in the morning hours could be higher because of REM sleep. So it's rather an underestimation than overestimation. But your residual burden would be you have 72 respiratory events, yeah, in that night. So your true AHI would be 9.
Yeah.
Okay? You don't get an AHI of 2. Yeah? You get an AHI of 9. That every MRD if it's well titrated, can achieve. If you think now about the week, and you see, you use it 5 days a week because on Wednesdays there is Champions League, and Champions League is now so late that if you go to your sports club, you know you'll be back so late, you won't use your CPAP, and you won't use it on Saturday night because you're returning from Berlin and you're fed up with it, so you leave it in your suitcase. So on average, we know people use CPAP for 5 days a week. Yeah, they don't use it 7 days a week.
Yes.
Most of them use it 5 days a week. So you've got 5 days a week where you got a well-treated patients, where you have your AHI of 9, but then you have 2 nights where you have your classical sleep apnea. Okay, so if you calculate your weekly AHI, on average your AHI is still 15 per hour. If you're an hour lab with an AHI of 15, we would say you're not well treated. Okay, so I think we have to go away from just thinking that optimal therapy is the time you spend on your machine. Your optimal therapy is your time you spend sleeping, okay? And that's something we have to take into account, because a lot of our patients, when they have their morning bathroom break from sleep, 5 o'clock in the morning, you know, they visit the bathroom, and then suddenly they look at their CPAP and say, well, you sleep for 2 more hours, I sleep for 2 more hours, okay? And they split, And, but if you take an MRD, they go with the MRD to the bathroom, they don't spit it in the toilet, they leave it in. And so in the early morning phases, which we know are very important in terms of treatment. Why? Because REM sleep has most severe sleep apnea and is noradrenergic. So we get most cardiovascular challenges in the REM sleep hours. That's where we want the treatment. So that's why I think, you know, we're looking at it the wrong way when we're comparing AHI of 2 with CPAP with an AHI of 5 to 10 with an MRD. It's the wrong way to look at this. It's not comparing the clinical efficacy of both treatments.
So go on with the Narval device. So I told you that it was created in Lyon, in France. Cocorico. So it was in 2002 with first prototypes, and we began to have some patients with the Narval startups. Was a very good startup in Lyon. And so the first patient granted and the conventional production in 2003. 2008, first patient treated using revolutionary CAD-CAM. It was technological leap. It was a technological jump for this moment. And so in 2009, we have seen Resmed and the first reimbursement of the Narval. So it was a little revolution in France, because we have many patients that you know, that have many medical care without paying anything, you know. So they were a little bit surprised when we told them you have to pay, and there isn't any reimbursement. I'm sorry. So go on. Thank you. So the Narval design philosophy. The Narval CAD-CAM is a Resmed product, therefore oriented towards OSA patients. And Narval CAD-CAM was based on repositioning the mandible and to the pressure, uncomfortable feelings due to the pressure on the incisor after wearing their device. So design of the Narval was driven by the aim to protect, of course, these very sensitive teeth in the front part of your mouth. So no retention, no pressure is taken on the anterior teeth. Anterior teeth are detectors, so they are very, very sensitive. The design was made possible thanks to the unique articulation and the CAD technology. So we go on this technology.
Just perhaps one side comment is, I've got no good training in physics and all of that, you know. So when everybody told me about that, you know, protrusion and all, I thought, like, what the hell, you know. You know, if you're a practicing sleep physician, test it yourself.
Yes, of course.
For example, I had an accident as a child. I have here all very, not only sensitive, but very expensive teeth up front here, you know, that you don't want to lose. Test it. Test it, and you'll feel the difference between the different mechanics of the MRDs. You know, it's not a chemotherapy. You know, you can test it yourself. Do it. Yeah.
Of course.
The funny thing is, most physicians then also feel they sleep better. You know, because they've got undiagnosed sleep apnea. But test it yourself.
And another precision. You might try a CPAP too.
Mm-hmm.
If
Absolutely.
you want to know what your patient feel every
Yeah.
night and maybe every night of his life.
Yeah.
It's very, very important.
Yeah, I completely agree.
Yes, it's
very
good.
important. Yeah.
Yes. So the innovation, what's the mechanism of the protrusion? And so you have forces parallel on the Frankfurt plan and a balance between protrusion and retention. So it's very easier for oral muscles for the comfort. The digital manufacturing is very important now, and we have 100% digital from the beginning to the end of this oral planes. Long-term efficacy in the ORCADE study, and the titration is very easy. Thank you. So the mechanism, I put this slide to compare what we have in France. Maybe it's not the same thing in other countries, but
It is.
in France, many people have monoblock, but it will be, I think it will be finished in few years. The bi-block fixed oral device is a test device now, and for short time. You recognize that Herbst or Herbst-like, it was maybe the principle for few decades, and so we are going to use the other. So here we have the study by Chaise and Bruno Navaille, our friend. He compared the compression-based articulation and the traction-based articulation. So they proved that biomechanical forces are less on the masticator's muscles with this traction-based articulation.
And I think, although I'm not an ENT, you know, we pulmonologists love nasal breathing. Okay, I think we underestimate the effect of nasal breathing that helps you with a successful treatment of sleep apnea. We're getting that lately, actually, with CPAP. Some colleagues recognize it also with publications. You can see the challenges that we have sometimes with full face masks. When you put pressure on the mandible, and the mandible moves backwards, and you can't get it open with PAP. Okay, and there you see the role, you know, of also different routes of breathing. So that's how I think if you can promote nasal breathing, you know, with the mechanics, I think that's an additional benefit.
To use the physiological, nasal respiratory, and to close the mouth without maybe pressure on your mandible. And don't forget the TMG. It's very important for the compliance. If you have a comfortable devices for all nights, you will use it, of course.
And you also get less mouth dryness, you know, if you close your mouth.
Yes, and the digital manufacturing, we also have physical impression with alginate or silicone, but now we are using the digital intraoral scanning of patient. You can go just and all steps of the manufacturing is digital, and welcome to the real world, virtual world, real world. You have your oral device, and you can treat your patient. Thank you. So, what are benefits? Maybe just this one. We have a high degree of customization, a consistent accuracy, of course, and then the computer-aided manufacturing with the laser polymerization. It's very sharp and very precise. So, and the device is very light, lightweight.
What it means, just advertising our last session at 11, you know, a whole digital process delivers data. From the data you learn, and you get artificial intelligence in the end. So you can automate that process in the next 10 years completely. Yeah, that's what's going to happen. Yeah, nobody wants to hear it. Come to our session at 11. Yeah, but it's going to happen. You can take the same with the car industry, you know, what was done man-made and what then, you know, with the automation developed. Same thing is going to happen to that, yeah? So, what's very important is something that we're lacking often in medicine is what we call post-marketing surveillance. Okay, so we bring a product to the market and then we'll start prescribing it. And we don't check the efficacy, what is now always called in the real world setting. Okay, with true patients, not with highly selected study patients. And so Narval has the biggest data set of post-marketing surveillance that's available in the world. And what's great is it's going to deliver more data because it's 5-year data. And there's a series of abstracts and publications. We're going to get the 5-year follow-up shortly. So we're going to run quickly through it. But if you're not certain about your product having evidence, this product has true evidence from real-world people out of everyday clinical practice. Yeah. And what you can see is also what they compared is the traditional way of manufacturing with the new way, and that's also an improvement in clinical efficacy. That's what we shouldn't forget. You nicely talked about, you know, that it's getting the better product. You know, it's fitting better the patient. Again, think about patient experience. The patient has a better experience because he gets a better product up front. He doesn't fail as often. Yeah, but we also get with that better efficacy, which is very important. So technology supports treatment outcomes. Yeah. And what we can see is, if we look at it with the AHI below 5, you know, it depends as always on your treatment severity. You know, and if you have mild sleep disorder breathing, you get very good efficacy in 70%. Yeah. So now a lot of people say, well, only 70%. Well, think about your CPAP patients. Okay, we know in CPAP, just 2/3 in the first episode of treatment will benefit from the treatment. Yeah, 1/3 will still have challenges, you know. It's not like CPAP fixes it for 100%. Yeah, so I think we get very good efficacy numbers, especially for patients with milder disease. Yeah, but I think looking purely at AHI is not the correct way. We have to more phenotype the upper airway. For example, we know that women have milder disease, but are better candidates, you know, for the Narval.
Appliance, yeah.
Genau. Yeah. So so it's got clinical efficacy. It's well tolerated, you know, and very important that you said. I think something that we're forgetting is noise in the bedroom. Okay. So and we're just always talking about snoring, but. No,
they will try. They will try.
Yeah, no, but the challenge is, as you said, you know, one thing is snoring. I think that we need to. That's the social burden of the disease. Yeah, that we need to fix. But the other thing is that also an MRD doesn't have any noise, 0. Yeah, no, it doesn't have. I mean, again, think about the patient perspective. Our goal is reducing sleepiness, and those results are absolutely excellent. Think about you're going from ESS of 11 to 7, that's an ESS reduction of 4. The data for obstructive sleep apnea, CPAP treatment, severe obstructive sleep apnea, which is called syndrome because of the symptoms, is an ESS reduction of 3 point something. Okay? So we get rid of this AHI notion. You know, think about the patient. You want to improve your patient, get an ESS reduction of 4. That is comparable to most of the narcolepsy drugs that we're giving in sleep medicine for narcolepsy as an example. That's a highly efficacious treatment. Okay, but get rid of that notion you're trying to treat an AHI. You're trying to treat a patient with symptoms, you need to improve the symptoms. And the study shows excellent long-term outcome. That's very important. Yeah? And same is for quality of life. We've got all the results for you in there. That's what we're trying to do. And I think quality of life is very important for patients. Patients' perspective is more on quality of life than on hard outcomes like mortality. Patients rather want to live better than want to live longer. Yeah, and so we've got very good data. And then, of course, the question is side effects. I think, of course, every treatment has a side effect, but I think those side effects are manageable.
Yes.
There are few side effects, and that's why we also need to be experts. You know, it's funny, if I get a lot of referrals from other colleagues, you know, for CPAP and for MRDs, patients with problems, challenges, yeah? And with CPAP, everybody knows, well, I can change the mask, I can put a humidifier. If a patient has a problem with an MRD, people say, oh, then you need to stop. You know, we've got no idea.
Okay.
Yeah? And so we need to get the same routine going for MRD, optimizing, I think, therapy that we have for CPAP. Yeah? And one of my favorite slides is this one, okay? Why? I tested MRDs myself, okay? When I first came to a friend of mine who is a dentist, and I showed him my protrusion, he was laughing at me. He said, where do you want to go? I had like 4 millimeters maximum protrusion, okay? And he said, well, we should give you 2/3, you know? He said, well, we could give you 2 or 3 millimeters, you won't go anywhere, okay? But then I tested overall 4 different devices, yeah? In the meantime, I have a maximum protrusion of 11 to 12 millimeters. Because I got used to it, yeah. So if you want to do stretching, yeah, at that age, yeah, you can start with that exercise. I mean, if you can, you're talented. There might be a talent in the room, but you need to start slowly. You start like that, and then a little bit more, yeah, and then at some stage you get to that. Think about the same. We're doing that with CPAP pressure. You know, we have patients who are pressure intolerant. We'll put the pressure down to 4, then we'll go to 6, then we'll go to 8. Think about it the same way, yeah? And then Darius will come up with the motorized version, you know, where it does it automatically, which he just promised us, yeah? But
we'll do it together.
Yeah. No, but think about stretching here. It can take time. What we do is, when patients are having challenges, reduce protrusion and then go gradually up, yeah? And then you'll be a very fit and healthy sleeper,
okay.
Yeah?
Satisfaction.
So, also, like we said, customer or patient experience is important. We have a great satisfaction, which we think is important because the satisfaction with the doctor is based on a doctor's treatment. So if we prescribe the right treatment, you know, the patient will be happy, and we've got really high treatment satisfaction. Data that we, by the way, don't have for CPAP. Well, we shouldn't forget why I'm always showing that slides. I'm showing you 2 more slides. Yeah. One thing is your 10-year adherence, that's Swiss data, very intense follow-up, yeah. In a very good Swiss clinic, after 10 years, 50% are still using their mask, 50. So every second patient has been lost, yeah? Okay. So we need to consider early on other treatment options because we don't want to just treat half of our population. That's not good medicine. Yeah, that would be a 2-class medicine. One gets treatment, the other not. Yeah.
And for French doctors, even if it's not reimbursed.
Yeah.
Yeah.
And the other thing is, that's I think is one of the most interesting studies in the last couple of years. It didn't get a lot of airtime because it's published in an ENT journal, not in a sleep journal. But they looked at the compliance over time. Because we thought, you know, we got better masks, and we got better devices, and we got better humidifiers. Well, you can see the compliance hasn't really changed over 15 years of CPAP, okay? Yep. So it's not about technology. It's about patient selection, patient identification, having a portfolio of therapies, thinking about what is the right treatment for the patient at the right time. And why not let a patient start an MRD? If sleep apnea gets worse at an older age, we can still switch. But then he's got a positive attitude towards sleep apnea and its treatment. Yeah? So we know that compliance with MRDs is better than with PEP therapy, especially if you think about the nocturnal usage time. Okay? Nocturnal usage time with CPAP is on average 4 to 5 hours. With MRDs, it's on average 6 to 7, it's longer. And I think we need a new compliance metric. The compliance metric would not be hours per night, but percentage of sleep time, okay? Because we're trying to fix the sleep problem. So I think MRDs are being used 90 to 100% of the sleep time. CPAP is 60 to 80, okay? And that's something that we need to take into account. We need new metrics to measure that. And I think that's why MRDs are highly efficacious, because they get a longer usage time, yeah, and with that, even if our AHI is a little bit higher, you know, we get at least the same treatment outcomes.
And thank you. And so the treatment is not just a medical treatment; it's really a hard discussion, and you have to negotiate your treatment with the patients. It's very difficult to be maybe with just one therapeutic solution, you know. It's very important. So the titration is very easy now with the split and to change these little parts of the oral appliance. And then it's yours.
No, yeah, what I put that in is just think about titration. I find it very important that Darius brought in the aspect of titration. Okay, it's also therapy that can be adjusted and it can be optimized. Okay, and there's a lot of data that shows the more protrusion we're getting, the better the result is. That's why a lot of people think, you know, I'll get an MRD, I'll give it to the patient, it's done. No, we can still optimize, yeah? And also look at how he's explaining you how you do the titration, because most people would think the longer those little bars are, the more protrusion you're getting. No, it's the other way around. So all I wanted to support is what Darius is saying. Think about it's a mechanical treatment that can be adjusted, and your adjustment can support better treatment outcomes.
And we can notice that it's about 5 or 6 millimeters, not more. Very important for ENTs, doctors, and dentists to get it in your mind. You don't have to go so far to have a good efficiency. It's 6 millimeters enough. Yeah. Hello. So what's the treatment protocol? It's easy, maybe. You know. At first, it's for you. What do you do?
I think it's first of all is I think outside of France, where we have an established practice, we have to change thinking about diagnosing sleep apnea means treating patients with a mask.
So we will have the patient for an oral device. When you have your patient, take some time to explain again, because in the first consultation with specialist, they will maybe remember 20% or 30% of your explanations. So you have to explain again and to tell them that it's not a dramatic problem. We have solutions and we will help them. It's very important for the psychological approach.
Absolutely.
So if you are, even if you are a dentist or ENT, you can you can speak to your patient. So dental examination, impression, maybe physical or digital, and then we will demand to Resmed for the manufacturing, all steps that you know now. It will be about 10 days if you have the digital device, and a little bit more if it's a classical. So you try it with your patient. He will go and try it at home, come back first time for the first control, and everything is okay, and you get the balance between comfort and efficacy. Then you have to tell him, please go and check your sleep with the sleep doctors.
I think he raised a very important point up front that I want to re-emphasize is find out what the objectives of your patients are. So find out what the objectives are, and we know, for example, like I said, we know roughly 50% are coming because their spouse is asking them to come. So their number one symptom is make my wife happy again, which is, as we know, that's why we males are living on this planet, to make our wives happy. Otherwise, life is a catastrophe. So if this is the objective, fix the problem. Don't fix the apnea. Get for the patient a solution that he can solve his problem.
Yes, of course.
And then write that down in your patient chart. What's the objective? And then when the patient comes back for the follow-up, don't again think, okay, I've achieved my goal because my AHI is from 30 to 2. Ask the patient if we've met the patient objective for treatment. Okay? That's a different way of thinking. So that's why I think it's very important that you say that at each step,
Yes, you have to
get the patient perspective.
Yeah. And so, what is your monitoring?
It's a very important point. I think what you need to do, as you say, once you've come through here and you are in a stable phase, you'll do a home sleep test. You'll do a home sleep test because as you showed with your titration, sometimes 1 millimeter extra can give you an extra benefit. But again, it's a trade-off. I'll rather have an AHI of 7, with a patient who likes his treatment and who meets his objective, then I'll give him an extra millimeter and I get the AHI of 3, but the patient gets more side effects. Okay? Work with the patient in a follow-up, meet the patient's objectives, balance it with your treatment objectives, and try to find the right way. That's why I think the monitoring down the road is important.
And you have to ask snoring, sleepiness, and all symptoms. And the first goal, the first objective is 50 or 60% of the maximal protrusion. Not more. It's enough. So, maybe we are a little bit late.
Okay. Yeah.
So, we have to follow up the patient with the oral appliance. Once a year, it's very good. Twice a year is difficult to organize. So, indications.
I think we covered that in terms of time. Just think about, I think it's very important what you said. We can't do it twice a year to follow up,
Yeah.
What we're starting to do is a little bit more, think about how you do a cancer follow-up. Yeah, you do it initially more intense, and the longer the disease is away, the wider your follow-up periods are. That's what we're starting to implement in sleep medicine. Initially, intense follow-up, but then it can get longer and longer. Yeah. And what we think is important is think about also if your patient suffers from snoring. It's not a disease, but you can still help him. It's still our job as a physician to help the patient. He's got a problem. Yeah. If you've got mild to moderate OSA, think especially also about females who have lower AHIs but higher symptom burdens. But don't stop with your thinking about an MRD at an AHI of 29. It's wrong. Phenotype your patient. If you've got a lean patient with a small mandible, 40 years old, his AHI could be 52, and still MRDs can be very successful. Yeah.
To have a dynamic view on the patient, the snoring is the beginning of the problem, and is a coupled problem. So you have to treat the snoring too.
I like that dynamic view.
Of the disease, the chronic disease.
Yeah.
Patients okay. And so, how are general contraindications? Of course, before 80 years old, because of the growing on the face growing, it's normal. Central sleep apnea, of course, any indication in this, and if your poor patient have severe respiratory disease. And some non-indications, or maybe loose teeth or advanced periodontal disease, short teeth, less and less problem for Narval, complicated dentures, of course, and other problems like that. So fitting of the device is very easy, and when you have the 100% digital way, you have few problem maybe, and tooth movement will be a little bit changed because of the forces, but you have to be very careful and make, as I told you, 50% or 60% the forward. Gingival dental soreness, pain in the temporomandibular joint, oral breathing and obstruction, excessive salivation in the beginning of night, and maybe dryness during the night. And I've never seen allergy, but I think that Narval maybe have some study like that. So the titration, very important. A first goal, it's between 50 and 60%. You have to know that you have to preserve maybe a little bit changing after the sleep test, in home tests. Do you want to precise something in this slide?
No, I think I like your dynamics between protrusion and symptoms. Again, take your time. Yeah, take your time. If I would have been your patient, I would have been lost in the first 6 months. In the meantime, I could go on further. So I think take your time. I like the dynamic view on the patient, but also on the process. Yeah.
And so, the monitoring.
And so I think what is important is, and of course, we know we have to do that within the framework of what your clinical practice is in your country. But I think what is important is follow it up and optimize it. Yeah. That's what we've done with CPAP all the time. If we just give a CPAP and we don't optimize, we have very low success rate. So don't be shy with an MRD not to change your protrusion, go back, then intensify it over the course of time. I think we can work with it, we have to monitor it, and the longer we're successful, the less we have to monitor it.
No. And so it can happen that patients decide to temporarily or permanently stop treatment with Narval CAD/CAM because of side effects or mobility of teeth. It's important to re-evaluate, of course, and the risk and benefits of the Narval CAD/CAM treatment, and to talk with your sleep doctor to find something, maybe to begin orthodontic treatment and the CPAP for 6 months, 1 year, and then switch again on a Narval oral appliance. Thank you very much.